Hey everyone, welcome. We're just going to give a second for all of our attendees to get into the system. Okay, we'll go ahead and get started. So welcome everyone to this webinar, One Health and Comparative Medicine in Medical Research with Drs. Rene Dimmitt and Rene Chambers. So I'm Bailey Archie, and this past year I have been working as the Educational Committee Event Manager for the International Student One Health Alliance. And I am becoming, right now we're in the process of transitioning, and I'll be the new Vice President of Education. And Andreas Pappas is our incoming president, who has been the VP of Education for this past year. And he is not here quite yet, but hopefully he will be able to introduce himself later on during the webinar. And these are our other new executive committee members. And I believe Samantha is here, so I will let her introduce herself. Okay, go ahead, Samantha.
Hi, Bailey. Oh,
Hey, Samantha.
thank you so much. Hi, how are you? Thank you so much. I am Samantha Mkonja, a medical student at the University of Nairobi in Kenya. I am currently serving as the co-vice president of marketing, and I am excited to be here. Thank you.
Perfect, thank you. Okay, so we're going to do a couple of polls of the audience just to kind of see everyone's background. So the first question is, what is your field of study or work? And you have the option to select one of these options. You can also select more than one. Okay, the top two responses are human medicine at 23% and veterinary medicine at 64%. And our next question is, what is your current level of study? looks like we are split pretty evenly between undergraduate, doctoral, and working professionals. And our next question is, where are you from? All right, looks like 54% are from the Americas, 23% from Africa, 20% from Asia, and 5% from Europe. So thank you everyone for answering those questions. Okay, now I'm going to move on to our speaker introductions. So we have Doctors Reed Dimmitt and Rene Chambers here with us today. Dr. Dimmitt is a professor of medicine at the University of Alabama at Birmingham, which is also known as UAB. He completed his undergraduate studies and earned his DVM, or veterinary degree, from the University of Missouri. And he practiced small animal emergency medicine in St. Louis, Missouri for 10 years before earning his MD from St. Louis University. He then completed a pediatric residency and fellowship in neonatology. And then he joined UAB in the Division of Neonatology and completed a fellowship in pediatric gastroenterology, also at UAB. And now he serves as the director of the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at UAB/Children's of Alabama. And we also have Dr. Rene Chambers, who is a professor of neurosurgery at the University of Alabama at Birmingham. She's the founder of the Alabama Comparative Oncology Network, principal investigator of the Southeastern Comparative Oncology Network, and founding member of the Comparative Brain Tumor Consortium at the Center for Cancer Research, which is part of the NIH National Cancer Institute. She's a principal investigator in K9, a canine immunotherapy trial, which is a collaboration between neuroscientists and clinicians at UAB and regional colleges of veterinary medicine. And it is funded by the NIH as part of the Cancer Moonshot initiative to support cancer research. Alrighty, so I'm going to let Dr. Dimmitt have the screen now. And then we will let him get started with his presentation.
Well, thank you for this opportunity. Can you all see my slides?
I just sent the request for your screen. Let's see. Okay, we can see it now.
All right. Well, again, thank you for this opportunity. It was really exciting to be able to kind of go back in time a little bit and review career as we're going forward. And again, I'm unfortunately not the researcher that I once was. I'm more administrative now, but at least to kind of tell a tale of this, how these two degrees and kind of the synergy can happen. So again, I want to describe a career in both human medicine and veterinary medicine, and then how each discipline was provided a basis for basic science and clinical research, and kind of describe how you can look at a human disease and where these techniques have been utilized. So as Bailey said, I started at Mizzou in 1975 and then graduated from vet school there in '82. I was in a small animal practice in St. Louis for a couple of years, and then went and was the medical director of the emergency small animal emergency practice in St. Louis in '92. Even then, I think that was probably the impetus for me to go back to medical school, was wanting to be involved in in research and kind of understanding, disease and pathophysiology. So Parvovirus was a hot thing. That was just pre the vaccine back then, and so it was something that we were inundated with and had a lot of some research kind of going on again pre-vaccine. And I assume this disease still exists in veterinary medicine, but also with with gastric dilatation volvulus. And so we were a site for the University of Missouri was treating puppies with parvovirus with IVIG, and were involved in some clinical trials with that, even when we were in private practice. And then from a clinical standpoint, we did a retrospective study looking at the epidemiology of the patients that we saw with gastric dilatation volvulus, specifically kind of risk factors for identifying which ones would end up needing some sort of surgical intervention as opposed to just medical management. So in '92, again, I was accepted into the medical school at St. Louis University. For me, it was more, again, a desire to care for children as well as to develop a more robust research career. Graduated in '96, and then went to Stanford and did a pediatric residency and a fellowship in neonatology. So a fellowship, at least in pediatrics, so residency is a 3-year study. Fellowship is a 3-year study, but one of it's clinical and 2 of it is research based. So it's a strong emphasis on research with that. And because my research was all somewhat related to the gastrointestinal tract, it was possible for me to do a kind of an accelerated fast track fellowship in pediatric GI, and I did that after I came to UAB. So as I said, I was involved in a lot of pediatric research, basic science during fellowship. My area of studies, at least during that, was liquid ventilation. We'll kind of go over that a little bit and kind of show how having a background in veterinary medicine was certainly advantageous to completing some of these studies. But most of my work has been on a condition called necrotizing enterocolitis, which is a disease of premature infants. And we'll talk a little bit about that in a little bit. So when term babies are born, they often have a problem where they have persistent pulmonary hypertension. In other words, they don't convert well, and they end up having to be on from an in utero to an ex utero situation and unable to be able to ventilate and oxygenate. And they have be put on several modalities of treatment. Some of those are ventilators, which provide support, but often can do damage to the lung because they have such high pressures. And in some of those cases, to prevent that, they're put on a heart, or at least a lung bypass thing called ECMO, which is extracorporeal membrane oxygenation, which again requires an operation. You have to put cannulas and catheters into vessels to provide that support. So the idea would be, can we somehow be able to avoid the damage done with ventilators and avoid ECMO altogether? So back in the mid to late '90s, there was a hope that this thing called liquid ventilation. So it's a fluorocarbon that can be put into the lungs, and it actually is a great exchange media for oxygenation. But there was some concern that it would maybe impact cerebral blood flow. So we did a study where we took 5 2-week lambs, and we underwent tracheostomy and then cannulated central venous pressure, or central venous access, as well as aorta and post-cerebral arterial cannulation. And we put these animals then on a partial ventilation. So we would wash out the surfactant and then instill the fluorocarbon, and then measure carotid blood flow, and showed that it didn't have any effect on that, which was again promising. Unfortunately, this was kind of left by the wayside, because what they found is, while it was a great exchange media, the pulmonary macrophages would pick these compounds up, and they would be in the lungs forever. And there was some concern about developing cancer down the road. So that there was a modality that had some promise, like I said, but is no longer being utilized. But my big interest, because I was a neonatologist, the disease that really interested me was this disease called necrotizing enterocolitis. And in this, the gut becomes very ischemic. There aren't really any good predictive markers for this, and so what we wanted to do was to look at a model of necrotizing enterocolitis. Again, this is during fellowship. We looked at called beta glucosidase this is a rat necrotizing enterocolitis model. And again, this is, I think, shows where having the ability of have been a veterinary surgeon to help with this research. So we essentially would put an ischemic reperfusion injury in rats, and so we would go in and do a laparotomy and isolate or identify the superior mesenteric artery and put a microaneurysm clip on. Dr. Chambers probably uses these all the time, but it's a clamp that allows you to decrease blood flow, but it doesn't injure the vessel, and so you can do ischemia and then reperfusion with this. And what we saw is that this again was a marker of this. So again, this kind of piqued my interest in an animal model for necrotizing enterocolitis. Like Bailey said, joined UAB in 2001 as a clinical neonatologist, but also had about 80% protected time and did a lot of research in NEC. So I did, some people are more basic science people, some people are clinical. Mine was to actually focus on the disease and try to come at it from both sides. So as I said, necrotizing enterocolitis, or NEC, occurs in about 10% of premature infants. The mechanism is completely unknown, but it does result in an ischemic injury of the intestinal tract. About 10% develop intestinal perforation and has a high mortality and morbidity rate in patients with surgical NEC. So my research focus was the role of mucosal immunity in an animal model of NEC, but also to determine the preferred surgical approach to patients with perforated NEC. Again, neonatologists, pediatricians in general, don't do operations, so this is getting kind of a unique role as a non-surgeon doing these kinds of clinical research. So the newborn kind of background, newborn intestinal tract is essentially sterile. And then infants acquire the microbiome during the first months of life. Premature infants have a delayed enteral nutrition and often treated with a multiple course of antibiotics. And some studies have showed that infants treated with probiotics and fed maternal breast milk have a lower incidence of NEC. So what we wanted to do first was to show that that there was a role for postnatal. I'll say that mucosal immunity was influenced by the acquisition of the intestinal microbiome. And so we have a large germ-free facility at UAB for mice research. But we wanted to kind of more recapitulate the newborn human model. So we basically did microbial reduce. So we had young mice that were treated, so the dam and the mice were treated with a myriad of antibiotics in their drinking water that allowed them to have a microbial reduced environment. And it showed that there was, that from a mucosal standpoint, from both T cell as well as B cell and other immune functions, that it required the acquisition of bacteria to have that happen. So this was, again, tried to go to this understanding of why probiotics or even the acquisition of microbiome is necessary to have a good mucosal immunity. Again, I'm not sure of everybody's background, but so toll-like receptors are things that sense certain bacterial proteins, and we wanted to show that is there a difference? Are these things necessary for when you acquire your microbiome? Do you then what are the mechanisms by which you then signal that, and is that protective against this? So working with Philip Tatum, who's now a neonatologist in Atlanta, we went back to the ischemia reperfusion model and looked at TLR4 and TLR2 and TLR2/4 deficient mice. What we showed was that if the mice were deficient in TLR4 in terms of recognizing and sensing LPS and endotoxin, but also deficient in TLR2, that they had increased injury from this model, showing again that while we think of these receptors as being involved in inflammation and disease, they also were protective in a way. And Dr. Chambers can probably talk about this, but unlike probably veterinary medicine, there are distinct camps. You are either a medicine person or you're a surgeon, and so they don't. And there's it's probably different nowadays, but back in the day it was very much a different world. But but I was really interested in the surgical approach to NEC. It's very controversial. Initially, when we had bigger babies, they all underwent laparotomy for a perforated bowel. But as we then had advances in neonatal medicine, we had smaller and more premature babies who didn't feel they could go through a major operation. And in 1978, a group in Canada reported this peritoneal drainage, putting a Penrose drain in the abdomen was also equally successful. And so this was actually one of the first studies comparing one operation to another in pediatric surgery. So Larry Moss was my mentor at Stanford, and we had a multi-center clinical trial looking at laparotomy versus peritoneal drainage for NEC and perforation, and found that the survival was the same in both groups. And so we were fortunate to get this published in New England Journal of Medicine going forward. So what are the advantages? So having a veterinary background provided a lot of benefits, at least in my medical career. I think certainly we talked about this offline beforehand, having comparative anatomy and physiology. I also think the importance of humane treatment of animals. That's a key, I think, as we go forward. And I think finding ways of doing this without having to involve animals is even better. But if that's the only way, to be again humane in that. Certainly specific hands-on ability, being able to do a laparotomy, be able to close the abdomen, be able to identify vessels, these types of things, being able to run my own anesthesia, having surgical procedures. But I also think because of having been, again, a veterinarian and involved in surgical care for patients, having an understanding and a basic, appreciation for what surgeons do, it allowed me to be able to involved in this type of research and prevent it at surgical meetings, which is challenging for a non-surgeon at times. But I think that background prepared me very well. That's all I got.
Great, thank you so much. And I will now give Dr. Chambers a screen. And for our audience members, just hold your questions until the end, please. And we'll give both of our presenters a chance to answer. Okay, I'm going to make Dr. Chambers the presenter. There we go. I can see your screen. Okay, you should be unmuted now.
Oh, thank you. Can you hear me?
Yes.
All right. Thank you, Bailey, for the invitation to speak, and to the One Health Alliance for coordinating this webinar. Yeah, I can echo everything that Dr. Dimmitt said. It's quite an interesting journey we've had. You definitely do not need to have both a DVM and an MD to do these things. It's our unique paths and the time in which we trained. It's worked out great for the two of us, to have both a DVM and an MD. But I think the way things are now, you can get involved one way or the other. And through the One Health approach, I think there's tremendous overlap now. We have we have an incredible amount of work where veterinary scientists and MDs are collaborating. And this is one example of that. So we've created K9. This is actually a One Health consortium studying genomics, oncology, and now immunotherapy. This is a project that we've been working on for quite some time at UAB. K9 is the name of the consortium, but it's also the name we've given to the current project. This began with a group called the Alabama Comparative Oncology Network. You see these names here. It morphed into the Southeastern Comparative Oncology Network and is now the K9 Consortium. But if you look at the degrees, it's all over the map. We have MDs, DVMs, PhDs, and a combination of quite a few. These are the investigators in the current project. This is not a comprehensive list, but these are the principal investigators at each of the veterinary sites, and then of course at UAB. You can, well, I've got more slides showing where the studies are. So a little background about cancer in animals. Over 4 million diagnoses will be made this year. Pet, dogs, and humans, which is the focus of our work, share so much. They share their environment, they share their carcinogen exposures, we presume. They are the only two species to sporadically or spontaneously develop lethal prostate cancer. Their breast cancers that develop spread preferentially to bones. They both have very similar osteosarcoma, and of course they both develop brain tumors, in particular gliomas. The history of veterinary to human translation, recent history, is shown here. I mean, it really does illustrate a number of things that have been developed for animals, in animals, specifically pets, and then translated to the human. The most recent significant finding was the small molecule or the tyrosine kinase inhibitors used to treat mast cell tumors in dogs, and now used for a number of ailments in humans, but in particular GI stromal tumors, pancreatic cancer, ovarian and prostate cancer. So our focus is on the malignant glioma, a tumor that originates from the glial cells, universally carries a poor prognosis. There have been so few advances in the treatment of this tumor. We've done the math. Over the last 7 decades, median survival has improved about 7 months, so that it's now just over a year. So if you map that out, it's a decade of research for every month of improved survival. That's pretty dismal. So we clearly need a new approach, a rational, correlative, hopefully molecular approach. And in our study, we're using immunotherapy or combination immunotherapy. Our rationale for using the K9 model in human studies and vice versa is we believe that this is a scientifically and ethically sound approach. These are not induced tumors. We're not giving a pet dog a tumor. We're having dogs who present to the veterinary hospitals with a sporadic or spontaneously occurring glioma. Based on information from the Canine Genome Project, I want to say 2005 it was completed, and they mapped 99% of the dog genome, 2.5 billion base pairs, and they found over 20,000 genes that were human orthologs, comparable to human genes. So there's great overlap. The dog has a much shorter lifespan, accelerating time to results in a trial. The similarities of anatomy, histopath, physiology, metabolism are very strong. The tumor initiation progression, very similar. The dog is a fairly homogeneous model when it comes to the genome. And importantly, the dog overcomes many of the inadequacies of genetically engineered mouse models. Latency in the tumor, the sporadic development of the tumor, the complex biology, the heterogeneity within the tumor itself. There are many different types of cells in one tumor, not necessarily easily treated with some magic bullet. It's a very heterogeneous mass. And then probably most importantly in the dog, an intact immune system. Most of the mouse models we've used have had some compromise to their immune system. So the One Health approach we think is wonderful. Some people call it One Medicine, but the One Health approach in this case highlights the idea that the pet dog is an ideal model for diagnostic therapeutic studies. We can translate successes in these projects to humans to inform human trials, but we can still offer the highest level of care to pets. And then the findings in each study, whether it's from the human to the dog or the dog to the human, are translatable in both directions. Just a little background on gliomas. This is the incidence rate in the US. You can see in the corner the incidence worldwide, and then new cases a year, over 10,000. Median age at diagnosis is 64, and an average life expectancy in the human of 79. Males are slightly overrepresented with gliomas, and the median survival is about 15 months. In the dog, actually very similar. Similar incidence, the new case rate based on the population of dogs, the median age and the average survival. Males and females are just about equally affected, or at least presented for care. And then median survival about 2 months. It can go 2 to 3 months. So now, and I have to back up and say, this number, of course, as everyone who's a veterinarian or veterinary student here knows, median survival or natural history of the disease in a dog is very skewed by the opportunity to perform euthanasia. But that's based on the best evidence we have, 2 to 3 months survival. Presentation of a dog with a brain tumor, typically seizures, ataxia, incontinence, or behavioral changes such as irritability, lethargy, circling, head pressing, just standing in the corner with their head against the wall. When tumors are advanced, they will increase intracranial pressure, and when they're significantly advanced to the point of impending brain herniation, whether it's uncal herniation you see in the pink arrow going down, or subfalcine herniation you see at the top of the brain, where the brain tries to cross over under the falx, will result in what we call Cushing's triad: bradycardia, hypertension, and an irregular, typically increased respiratory rate. With uncal herniation, this the uncus, or the part of the brain trying to slip down below what we call the tentorium, it can compress the third cranial nerve and result in dilation of the pupil. And of course, in severely advanced cases, you'll see decreased level of consciousness. That's how a dog will typically present with a tumor. Human patients more typically have altered cognition. Something's not right, and they notice it. They rarely present with a headache unless it's very advanced, which is how tumors get so large before they come to our attention. Supportive care, pain management, preventing seizures, oftentimes steroids just as an anti-inflammatory. And then standard of care is surgery, radiation, and chemotherapy. Chemotherapy most often used is Temodar or temozolomide. And again, this is an example of human protocols that have been translated to the dog. Well, with our work we do here on oncolytic viruses, along comes the cancer moonshot in 2016. The NIH sort of came up with a program of precision medicine. They had numerous fields of study on which they wanted to focus to basically shoot for a cure for cancer. So they offered an RFA, a request for applications, for anyone who could demonstrate that the dog was a good model, an appropriate model for the study of human cancer. And they wanted to know what centers could perform combination immunotherapy approaches to different cancers. Follow the anti-tumor response in the dogs, obviously dogs with spontaneously occurring tumors, pet dogs, and then translate these findings to the human. Well, this was just, this felt like a love letter to our department. This is exactly what we've been working on. And with my background as a veterinarian and the Alabama Comparative Oncology Network and the Southeastern Comparative Oncology Network, we were sort of made for this. So the sites that were awarded the UO1s are listed here. We were among those. There were 5. And UC Davis, UAB, Colorado State, Tufts, and Minnesota, all studying different cancers, from bladder cancer, osteosarc, B-cell lymphoma, and glioma. And then the coordinating center is at the University of Pennsylvania. So this is a 5-year project. We're in year 3 right now. Canine, in this case, I'm using it as the name of our study. It stands for Canine Immunoneurotherapeutics, which is basically what we're doing here. This is the first study of immunotherapy in dogs with an oncolytic virus, a virus that will attack tumor cells and leave brain cells alone. And this particular virus expresses IL-12, which is a cytokine known to stimulate an immune response. Our sites within our consortium, we have 5. UAB is the hub where we do the data collection and analysis, and then the veterinary sites are listed here. In stage 1, I'll just give you a little bit of how we do the trial, how it works, and then our results to date. We inject a herpes virus called MO32 into the tumor bed after we perform surgery to resect the tumor. A study from 2012 has shown that canine lymphocytes do indeed respond to human IL-12. So that was an important point to make before we began. And then in stage 2, we have not yet begun stage 2. The next 2 or 3 dogs from now, we'll begin stage 2. We will provide daily checkpoint inhibitor orally to the dogs after they complete treatment in stage 1. So our goals in this study are to establish the safety and tolerability of the treatment, to evaluate the immune response of the dog and correlate that to their survival, and then finally to conduct genomic studies, sequence the tumors. So our virus, this is just a quick slide to show you how far back this goes. In '94, we were evaluating the feasibility of using an oncolytic virus for brain tumors and trying to perfect the virus through genetic engineering to make the virus focus on glioma cells, not infect brain cells, but infect the tumor cells. And this was the first iteration of the virus up in the right. We've had numerous modifications to that over the years. We have 3 human clinical trials going on now. Dr. Dimmitt probably has talked to the neurosurgeons over at Children's, and they are using one called G207 with children with glioma. We're using C134, a slightly modified version of MO32 in a human trial right now. So this is not something we're using to experiment in dogs. This is a treatment that we are translating from the human to the pet dog. And we're expanding on it in this trial, and then we'll take those results and translate it back to the human. The second part of our study, after we've performed surgery, infused the tumor bed with virus, then we will follow with a month of this oral checkpoint inhibitor. What we're using is indoximod, and indoximod has 3 functions. It's basically immunostimulatory. We're trying to stimulate the immune system. Same with any checkpoint inhibitor, you're trying to stop suppression of the immune system. So indoximod will stimulate effector T cells, increase their proliferation. It will reprogram Tregs to T helper cells, good, useful lymphocytes, and it will directly downregulate the production of an enzyme, IDO, expression specifically in the dendritic cells. IDO, I think I may have to tell you a little bit about that enzyme later, but it is an important enzyme that converts tryptophan to kynurenine, and that results in T cell inhibition. And so indoximod blocks that. What we're trying to do is allow the immune response to proceed without inhibition. So the sites, UAB, Mississippi State, Auburn, Purdue, and Georgia presently. Tuskegee is involved, but they're not enrolling patients. In stage 1, following surgery, we place this catheter. It has a little reservoir that stays under the skin, like any port you can inject through it. We inject the MO32. In stage 2, the dog is treated with the indoximod for a month after the surgery and infusion of virus. So just to review the study itself, and then I'll show you our outcomes. The virus has a deletion and basically an insertion so that it expresses IL-12 so that it will infect tumor cells without infecting brain cells. It's non-neurovirulent. It's very antigenic. It stimulates or activates toll receptors. Toll receptors are receptors on immune cells that recognize molecules that will stimulate them. So basically, it's immunostimulatory. That's about the simplest way I can say that, sorry. And also it will cause the release of IL-12. So the tumor cells are becoming sort of a factory for virus production. As the tumor cells die, they release IL-12. This further stimulates the immune response. Now you have a tumor debris field. You have dead tumor cells stimulating an immune response. You have the virus that has ramped up this immune response, and through cross-epitope spread, in other words, we want these immune cells to, once they recognize the virus, they're stimulated by IL-12. Now we want them to recognize a number of antigens in these tumors, and this will become an anti-tumor response. Finally, this is what I was mentioning earlier. Tryptophan is converted to kynurenine by IDO, and this IDO is expressed in high-grade gliomas. So that process results in the depletion of tryptophan and suppression of the immune system. So the tumor thereby evades the immune system. If we give indoximab, this is an inhibitor of IDO. So we hope to prolong the stimulation of the immune system that results from the virus. So this study, to date, we have approximately 22 dogs enrolled. And if you're familiar with the Kaplan-Meier plot, the y-axis is the proportion of your population still alive. Each dot represents a patient. The living patients are represented as red stars. And the x-axis is days of survival after treatment. So we just said the median survival is 60 to 90 days. Our median survival in this study, the 50% of the population, is 188 days. So we clearly have an increased survival in this particular cohort. And we still have dogs alive. And this is stage 1. This is simply with the viral treatment. So the significance, we think, of this study, it provides an opportunity to evaluate this combination therapy long before we would have been able to initiate some trial like this in humans. The virus has already been evaluated for safety in numerous species, primates, dogs, mice, and humans. I like to say we tested this in humans before we put it in a dog. And then concurrent trials. The fact that we have 3 ongoing trials in humans gives us an opportunity to compare results real time. We can look at results from each species and really work in a bi-translational fashion. So we believe this is a novel immunotherapeutic approach. It's proving effective and safe with increased survival times. It provides an alternative to standard of care in the pet dog, where surgery alone or surgery with chemo and radiation is currently the best we can offer. It gives us an opportunity to identify new targets and agents or treatments. And we really do believe it's a bi-translational program that can benefit both species. Again, as Dr. Dimmitt pointed out, and I say this in jest because I'm very pleased with the path I've taken to get here, but I would not recommend that you go this way. If you finish that, you will be an old woman before you start a research project. And so again, here are the investigators currently working on K9, and I would encourage you, if you have time, to visit the website. There's a lot of good information about the project, the personnel, the principal investigators, news articles, a lot of general information about using not only combination immunotherapy, but also using the pet dog as a model, and also contact information if anyone wants to reach out and contact any of us. Thank you again.
Great, thank you so much. And I will take back the screen now. Okay. So now we can take some questions from the audience. And I saw that we had one submitted in the question box. Let me see if I can go back and find it. From Kristen Bagley. So I will unmute you and you can ask your question out loud if you'd like.
Yeah, that sounds great. Can you hear me?
Yes.
Wonderful. So thank you guys both for sharing your career paths and your work with us. My question was, what influenced your decision to pursue an MD instead of like a PhD or like a veterinary residency in like lab animal medicine or veterinary like anatomic path or something like that?
Dr. Dimmitt, you want me to go first?
Would you go first?
So I actually went back to medical school out of an interest for neurosurgery itself, not for the research. So PhD was not in my future. I have to say it was serendipity, you know, just as I alluded to when the cancer moonshot came along. Although I had an interest in treating brain tumors, it wasn't until that came along that it was just a perfect opportunity to combine the two degrees. And that's why I sort of jokingly said, you don't have to do both degrees. You could do one or the other and then pursue your interest. I had family members that were affected by neurosurgical diseases. And so that sort of prompted my interest. And as everyone in veterinary medicine knows, there's a significant limitation at certain points where euthanasia is a very real option. And although that's fabulous, that's wonderful, I'm so grateful that we have euthanasia as an opportunity to spare an animal any suffering, it also thwarts a lot of treatment and research to novel treatments, and certainly advanced research where it's very expensive, very time consuming, and may result in some suffering or prolongation of a life when the animal's suffering. So we very wisely euthanize animals. But for me, that was a point where I thought I'd really like to pursue research and treatment beyond the stage where we typically euthanize an animal. And humans, since we don't have that option, it was sort of a natural thing for me to go to MD. I hope that answers your question.
It does. Thank you.
I would mirror that. For me, it was more a clinical decision because, again, I said I wanted to be involved in some sort of, pediatric medicine of some sort, but also with the idea that exactly that I wanted to understand and be able to kind of go beyond. You get to a certain point, and then your pet is euthanized, and you feel like you may be could even do some more good, and that's what prompted me to do that.
Thank you.
Yeah, that's a great question. It's there's so many different factors, but from a research standpoint, if I had strictly wanted to do research, I would have gone for a PhD rather than an MD.
All right, thank you both. And we have a question from Mayra Guzman, and I will unmute you if you'd like to ask your question out loud. Mayra, you should be able to unmute yourself if you'd like to ask your question.
Can you hear me? Oh.
Yes.
Oh, okay. So thank you both for sharing. I guess my question was already answered about pursuing a PhD after instead of an MD to work in the same field that you're working now.
Okay.
I don't know if you want to elaborate on that a little bit. Right now, I'm a DVM student also, and I'm working with gliomas and mice, but I'm interested in working with canines. So if you could do it now, it would be a path that interests you.
So I would say absolutely a PhD is perfect for you if you want to do canine brain tumor research. I mean, that's ideal. There's certainly no need for you to pursue an MD. And there's so many opportunities, whether it's through the veterinary colleges, working with the NIH, or working in a medical school. You know, we have an animal resources department here that's huge, and it's run by a veterinarian with plenty of opportunity for research. He actually was instrumental in coordinating a lot of the people involved in this study.
Okay, awesome. Thank you.
All right, and we have a question from Elizabeth Mancy, and I will unmute you. You can ask your question.
Yeah, hey, I'm a vet and I'm doing an MPH right now, and I think I'm gonna go do a PhD. But I don't want to be involved in like lab animal medicine. So other than UAB, are there any other universities doing this type of non-lab animal translational medicine?
Yeah, well, from my standpoint, yes. And if you look at the Cancer Moonshot information, you can literally go to the NIH or NCI website. And this Cancer Moonshot effort for precision medicine, the canine immunotherapy studies is just one example. The Canine Brain Tumor Consortium is another. There are so many universities where, yes, you can do more than lab animal research. You know, Purdue has a great program with translational medicine through pets. UC Davis has a long history of that. Pete Dickinson is a veterinarian there that does great work with Arta Monjazeb. I think they actually were one of the first to work with the checkpoint inhibitors. Yeah, there are plenty of opportunities. It's a little bit of a challenge for you to sort of pick and choose through websites, but probably the NIH is a good place to start. And I'd say Dr. Amy LeBlanc is the director of the Brain Tumor Consortium there and the head of the Comparative Oncology program. She's probably a great person to talk to about it or to email, and she's available through the website at the NIH, Comparative Oncology Program, COP.
Great, thanks so much.
Sure, yeah, good luck to you.
And getting back to the whole lab animal thing, I think it's an interesting journey. We were talking a little bit about kind of the molecular biology explosion that occurred, you know, a decade or so or more ago. You know, there was a time when, I mean, anybody could make a knockout mouse, anybody could make a, you know, transgenic mouse that would mimic a human disease, but they're not the human disease. And I think we're, at least as I read the literature, I think we're moving away from that as much to where, again, more of a precision thing, using a different, it may be a lab animal, but it may be a worm, or, you know, something that's a little bit different, that we can actually not have the, what, you know, not doing experiments in animals, to be honest with you.
Yeah, and I think I'm leaning towards a PhD in epidemiology, so that I can avoid that completely, and I can just, I figured I know how to do, you know, the animal medicine. It's only going to be helpful, but it doesn't, you know, when you're just reading papers and reading statistics, who cares if it's animals or, you know, and people? They're, that's true. I don't know.
Okay, great, thank you. Looks like we have a question from Sandeep Rathod, so I will unmute you if you'd like to ask your question.
Hello, am I audible?
Hi, we can hear you.
Yep, thank you. Thanks for the nice presentation. I was very keen that One Health being a very novel concept, and we know that the environment, animal and human have a close interaction. So are there multidisciplinary teams working across the world for the One Health concept implementation?
Can you hear me?
Yep, definitely.
Yeah, I'm so sorry. Would you repeat the last part of your question? I'm sorry, I sort of cut out.
multidisciplinary teams working for the One Health concept implementation. It's like professionals from the handling the human health project and animal health project and environmental health project working for materializing the One Health or implementing the One Health strategy on ground.
Are there other teams? Is that what you said?
Yeah, like any classical example of few of the countries or which are well known for the One Health concept implementation on ground.
I don't know, Bailey, you may know better than I do about that as far as other teams. And I think I heard you correctly when you said working worldwide.
Yes, like I could read some of the South African action plans related with the One Health implementation strategy. But if there are any example, I will be glad to know. Over.
I mean, I don't know that. I mean, I would think the closest we'd have here probably is public health, initiatives. But I don't know of any other than what Dr. Chambers was talking about in terms of crossing over.
Yeah, I think again, the NIH may be a place to look there. The comparative oncology. Now that's just for cancer, but I assume you mean for any One Health approach. It might be your own organization, the One Health group that could. It seems like maybe, I don't know, Bailey, do y'all have resources that show different efforts that are going forward from the One Health Alliance?
Yes, I can put in the question box links to the One Health Commission website, which is kind of the parent organization of our International Student One Health Alliance. And the One Health Commission's website will have tons of resources on One Health initiatives happening worldwide.
And there are many. There's an annual conference sort of exhibiting those.
Yes. Yeah, and like Dr. Chambers said, I'm sure the NIH website would also show maybe comparative medicine research going on internationally. Is that right, Dr. Chambers?
That's right.
Okay, great.
Yeah, thank you for the information. I will try to explore the same.
Well, I'm sorry it's not more specific.
Hello?
Yes, we can hear you.
Yeah, I said thanks for the information. I will look forward on the NIH and some other websites.
Okay, great. Thank you.
Thank you.
I think it might be, if you're looking for a website, it might be cdc.gov instead of nih.gov.
Yeah.
Yeah, and just search the One Health at cdc.gov, and I think they will have a list of a lot of, collaborations, interdisciplinary work, and they do local, regional, national, and probably global on the CDC.
You read, at least you hear, I don't read the veterinary literature as much anymore, but there has been some crossover of COVID-19. People are talking about. It wouldn't surprise me if that's going to be an initiative into the future of understanding, that as the pandemic as it relates to both human and animal.
Absolutely, yeah. I mean, the thing about One Health is it becomes more of a sort of global focus on zoonoses, more than it does comparative work like this. It's truly looking at how the animals, all types of animals, not just pets, but animals, humans, and the environment all interact and share sort of the microbiome. It's a much more global, if you will, approach, but there's still a lot of resources available at their website, which is basically the cdc.gov One Health website.
Sure. Thank you.
Sure.
And also the One Health Commission is currently working on developing a webpage with links to a bunch of popular media articles about a One Health approach to COVID-19, either prevention of future pandemics or surveillance of zoonotic pathogens and things like that. So I can also share that link in the follow-up email.
Well, and Bailey, as you pointed out, one of your interests was the food animal medicine, and I think you sort of alluded to global health security. So that's a very important thing. If you look worldwide, that's another facet of the One Health approach, is looking at, just like you said, and Dr. Dimmitt mentioned, the pandemic, the food animal medicine, antibiotics, security. I mean, there's so many different facets this takes. It's pretty endless.
Right, right. Okay. Do we have any more questions from the audience? You can raise your hand if so. Let's see. Okay, I see a hand from Michael Rampetti. I'll unmute you.
Yes. Greetings, and thank you for giving such a captivating presentation. And I just wanted to ask Dr. Chambers about the canine being a good model for her kind of research. Is it just is it just a dog, or carnivores in general, or any other animal that may present similar clinical symptoms that makes it a good?
That's a great question. Any animal could be a good model. We're blessed using the dog that there's been so much work done to identify the canine genome and compare it to the human genome. So if we want to do this work, we don't have a feline genome project. We don't have as much information with the entire genome laid out. And I didn't mention this on one of my slides, but there was a boxer named Sasha, and that was the first dog used to create an idea of the genome. We've since done much more work, and especially a doctor named Elaine Ostrander at the NIH. They've done a great deal of work to map the genome of the dog, superimpose it on the genome of the human, of course with a different number of chromosomes, but find all the orthologs. And so for that reason, and in my work in particular, the dog is ideal. But certainly this could go, and as we learn more about each animal, any animal would be a great model. I mean, well, I can't say that with certainty, but I would assume that certain diseases would have an ideal animal model. For instance, the golden retriever would not be an ideal animal model for the glioma, because they're a dolichocephalic or a long-nosed breed. They tend to get meningiomas if they get a brain tumor. Whereas the Boston Terrier or the Bulldog with the brachycephalic or the short nose skull, they tend to get gliomas. So you can see right there just one small example of how the dog is such a good model. This particular breed of dog is such a good model for this tumor. And we already have so much genomic information about the dog. It's a burgeoning field of study. But yes, any animal could become an ideal model for any disease.
All right. And one more question. Having been exposed to the best of both fields in terms of vet and human medicine, would you say that the One Health concept is embraced well by both fields, or would you rather advocate for a more collaborative approach in terms of the curriculum itself? Or
Dr. Dimmitt?
I think we're always looking for more collaboration. I think within a discipline and across discipline, I think there's always room to do much more than we're doing, right now.
I think historically, veterinarians, in my experience, have been more open to the One Health approach. I think that has changed significantly in the last decade, when veterinarians have educated MDs, and MDs have sort of been introduced to the idea where previously they were not. And none of us were introduced to this in the curricula, but I think MDs are sort of being educated now and realizing the value of this. And then, of course, if you do any Google search, you can't miss it now. So I think it is, like Dr. Dimmitt said, I think MDs are completely open to the idea and collaboration where they may not have been before. I really think it's the same attitude by both professionals now, but the resources are greater in human medicine. And so even if you're a veterinarian and want to do One Health work, I think the NIH is getting better about providing funding to veterinarians, but they're still underrepresented. So you want to collaborate with a medical professional because that's where NIH or industry, not necessarily industry, but also industry funding is more available. You got more money, you get more done.
I see. Thank you so much.
Oh, you're welcome.
Okay, I think we have time for one more question if anyone wants to raise their hand. All right, we will move on to some announcements from the International Student One Health Alliance. And Andres Pappas, our president, is now here. He's just gonna say a quick hello, and he can also touch on these announcements too.
Hello, everybody. So I am Andres Pappas, a vet student from Greece, and I was the previous year the vice president for education, and this year the president of ISOHA, this year that is coming. So I'm so sorry for not attending earlier and not introducing myself from the beginning, but I was facing some issues. So, but now I'm here with you, and I would like to thank everybody for coming. But first of all, the lecturers who talk for us, Dr. Reed and Dr. Rene. I participate only in the last part of the conversation, and I find it very interesting. I am sure that the rest was also very helpful for everybody, and you get a lot of knowledge, and it was nice an opportunity for you. So yes, last but not least, I want to thank very much Baile for organizing all this event, because you did it by your own, and we need to congratulate you for that. So what else I would like to mention to you? That a new year is coming. I mean, this is the last webinar of this year, except one meeting that is left. The next year we are planning to start new things for you. So don't hesitate to contact us for anything you may need, or me personally. And I wish all the best for the upcoming year and the new committee. So what we have here as announcements, I'm sorry, I didn't check earlier. So maybe it's better you, Bali, to say the announcements.
Yes, so soon we're going to be releasing applications for continent representatives as well as educational committee members. So you can see the duties of the continent representatives and educational committee here, but as the continent representative, you would basically be a liaison between the executive board of ISOHA and student groups or individual students in One Health on your continent. And then the educational committee does a majority of the programming for ISOHA. So we do things such as webinars like this. We have a mentorship program, an educational journal, and we also have maps and lists of resources for educational opportunities like degree programs or internships in One Health. So basically, on this committee, we work on all of those things, and there will be a few new positions announced on the educational committee this year than we've had in the past. So we're looking forward to that, and you'd be working with me. So I encourage everyone to apply when those applications go out in the next few weeks. And I see a couple more questions just about ISOHA in general, so I'll try to answer those really quick. So Michael, we do not currently have a way that one can become an official member of ISOHA, but in the follow-up email, I'm going to link a list of resources that go to our website and our email list, and things that can help you get connected with ISOHA. We're considering establishing a more formal membership system. So if anyone has thoughts on that, you can contact us at this email address shown here. Yes, you can contact us here if you have any thoughts on establishing formal membership, if you would like that or if you would not like that. Alrighty, I think that is about it. Feel free to check us out on our social media listed here. Thank you so much for joining, and thank you so much to Dr. Dimmitt and Dr. Chambers for taking their time to share with us. And thank you. And a big thank you to the One Health Commission for providing the GoToWebinar platform for us. So with that, I hope everyone has a great day, great night, wherever you are, and hope to stay in touch. Bye.